we know about PARP inhibitors in general is not only do we think about them as a maintenance strategy, many of us think about ovarian cancers in remission as microscopic tumor sites that reside in the peritoneal cavity. So maintenance really has some treatment component to it. What we know from additional studies that were done, particularly one in which Dr. Oza was the first author, published in Gynecologic Oncology, they really looked at efficacy in a pre-specified patient population in a cohort of patients that emerged from both study 10, a Rucaparib study, as well as a cohort of patients that were adopted from Ariel 2 part 1. And these were a BRCA mutate patient population specifically, somatic or germline. And in that cohort of patients for efficacy data, they saw a ORR, an overall response rate of 54%. And in addition to that, 61% had greater than or equal to 3 prior lines of therapy. So you have a heavily pretreated patient population with an objective response rate above 50%, which is really exciting data for us because, as we discussed previously, with each disease recurrence, the magnitude of benefit declines. And if we have patients who've had at least 3 or more prior lines of treatment with an overall response rate of greater than 50%, it suggests efficacy of this regimen even in that population. And there is additional data that's important to highlight when we talk about efficacy of Rucaparib. The Ariel 3 study, which was in the platinum-sensitive recurrent setting, allowed patients who had a partial response in what we call bulky disease left over that was greater than 2 centimeters after completion of their cytotoxic chemotherapy. And even in that population, we saw meaningful response rates, suggesting that the PARP inhibitor is effective therapeutically, even for those patients who have measurable disease that remains after cytotoxic combination chemotherapy is completed. Loss of heterozygosity is one of the markers that we would consider reflective of genomic instability. The theory behind the assays that we do to evaluate for what we call homologous recombination deficiency, which LOH or loss of heterozygosity is a component of. When we are doing these as assays, we are trying to determine whether or not we're going to identify a vulnerability in the tumor that helps identify patients that may benefit from PARP inhibitors such as Rucaparib. Again, Ariel 2 Part 1 specifically incorporated an LOH assessment in that population with a cutoff of 14%. That was revised in Ariel 3 to 16%. The relevance of this is that patients who have an elevated LOH score or who have homologous recombination deficiency appear to benefit or have a greater magnitude of benefit over what we would call a biomarker negative population. Patients who are BRCA mutated, by definition, are homologous recombination deficient. So the LOH score doesn't really apply to a patient who has a known germline or a somatic BRCA mutation. But there is a caveat here, and that caveat stems from the fact that this is not a perfect assay, meaning that LOH is not predictive of response with a sufficient sensitivity to define patients who would benefit only by that way, that mode of assessment. There are patients who are BRCA wild type and who are LOH low or homologous recombination proficient who will still benefit and have a meaningful response. In fact, in the Ariel 3 study, I think amongst that cohort, there were 30% responders to Rucaparib versus 5% in the placebo arm. So you can see that it's not perfect in predicting response because patients who are LOH low and BRCA wild type may still respond to PARP inhibition. And that ties to the FDA approval of niraparib in the frontline for all comers based on the data that was released after the PRIMA trial.